All right, well, it's a couple minutes past 2, so I'm going to go ahead and start a welcome just in the essence of time. And I know we have a lot of important information to cover. My name's Janine Yanish Jones. I'm the Executive Director for the Health Alliance for the Uninsured, and I have a dual role. I'm also the chair for the Oklahoma Charitable Clinic Association. So I'm really honored to get to be able to provide trainings and information to the free clinics and our partners statewide. This is an extra special partnership that we have that we're being able to feature, I guess, today through this training. And that is a partnership that developed through the work that we were doing with and continuing to do with our United Health Foundation grant for the Shared Hub approach to providing enhanced services. We call it SHAPES program, and working with the uninsured diabetic patients in free clinics. And part of that partnership and work is doing screenings for behavioral health, substance use, tobacco use disorders. And that as we were looking for a wonderful partner to work with, we serendipitously got introduced to Cheryl and Chuck and their team. Chuck is kind of behind the scenes here, Tyrone. He's running our some of the audio visual materials for us, and he is the knowledge and project management for the University of Oklahoma School of Community Medicine. Also, I think we have more people here joined. If you would please put your name, organization, and email in the chat, that would be great, because we are going to keep kind of an attendance listing, because this is a really wonderful donated program and service that we're getting to provide. I was saying earlier that I'm excited that we're offering this in May. May is Mental Health Awareness Month. It kicked off yesterday. I'm wearing my green. I don't know if you can see it, but green is the color for mental health awareness. And it's an important time to remember to check on your friends and family. If you haven't seen somebody for a while, check in with them and say, hey, how's it going? I haven't heard from you in a while. Is everything going okay? That's Dr. Brand's going to have a million suggestions on how to help and support one another. But that's my simple tip of the day is, reach out and love on your neighbors, especially during this month. I would like to introduce Cheryl Critchley. She is the lead practice manager. Kind of messed that up a little bit. She's super smart. And what she does is she's working statewide with practice facilitators who are going into free clinics and a lot of other organizations, institutions as well, and helping with what's called an expert screening. And that's what I described earlier, the substance use and tobacco and mental health, behavioral health screening tool. We're really excited to start being able to offer some more holistic opportunities, especially in the free clinics. And if you're interested in learning more about that, please feel free to message me. I would be happy to talk to you about how we can do that, because the more resources that we can get to people, the healthier our community and state can be. So with that, I would like, and Cheryl's that holds that role and title with the Oklahoma Primary Health Improvement Cooperative. Cheryl, you're gonna have to correct me.
You're fine.
Okay, and so which we call OFIC with it, but we're excited, so excited that you're here. We're excited to learn this information. Thank you, Dr. Brand and Chuck, also for making this possible. And I'd like to turn it over to Cheryl.
Thank you, Janine. We really thank the Health Alliance for the Uninsured for inviting us in to do this project, and we're really enjoying it. We also have Missy McCullough on the call, who's one of our practice facilitators, which is our title, and what we do with practices to help them improve their practice and patient care by learning about new guidelines and opportunities to do that, and improving their quality checks that they can do on themselves. But anyway, I appreciate Chuck being here to run some things for me and for Dr. Brand. And please, when you put your name and organization in the chat, please put your title as well, your role in your organization. We do report to the Oklahoma Department of Mental Health and Substance Abuse Services, and they are our sponsor. So we're she already made mention of that, but I also want to make mention of that. And without any further ado, we're going to turn it over to Dr. Michael Brand, who is the at OU Health Sciences Center in Oklahoma City. He's the vice chair of social work. He works with adult mental health and child adolescent mental health. He has a PhD and LCSW, if you know what those titles mean. He'd be happy to talk to you about that. He has helped us on a prior project called Do No Harm that was pain and opioid management, helping us put together some training materials for that project. And he's been presenting this presentation that he will tell you about in just a bit. So I'd like to welcome Dr. Michael Brand and let him get started. And he's going to just tell me when to change the slides or run a video or pull up a link. So.
All right, Cheryl, thank you. Thank you, Dr. Jones. It's good to be with you all today and talk with you a little bit about suicide prevention. So this is a program that the Oklahoma Department of Health and Substance Abuse Services has gotten behind, and it's really a good overall program to reduce the problem of suicide and increase prevention and awareness. So first off, Cheryl, can everybody hear me okay? I want to just make sure before we get too far. All right, good. Okay, I see some thumbs up and some head nods. Good. Okay. So we'll take a look at it, and then we'll stop along the way and look at some of the resources and stop along the way for questions or comments, those kind of things. So Cheryl, I think we can go to the next slide. So this is a little video that'll kind of give you an overview. So we'll go ahead and play that. We can take a look at it.
Every minute of every day, suicide impacts the lives of hundreds of people across the globe. It robs families of loved ones, young people of their future, workplaces of colleagues, and communities of their most valuable resource, their people. And surprisingly, of the 800,000 people a year worldwide who die of suicide, most saw a healthcare professional in the year prior to their death. Contrary to popular belief, the problem isn't that those at risk are disconnected from healthcare. It's that gaps exist that allow these individuals to slip through. Despite this, healthcare has remained unchanged, presuming many deaths were tragically inevitable. Inspired by the Henry Ford Health System in Detroit, Zero Suicide is a call to action based on the belief that no suicide is fated. It all starts with zero because a radical and systematic approach to perfection is the only way to create dramatic change, and it must be driven by leadership's commitment to creating a new culture around suicide prevention. 3 specific evidence-based interventions have emerged as central to Zero Suicide, creating the multi-layered approach that helps ensure no one slips through the cracks. First, we must make it okay to talk about suicide. Healthcare must routinely screen for suicide risk at all patient touchpoints within a health system. Simple screening questions like, do you have thoughts that you'd be better off dead or hurting yourself, allows healthcare professionals to start a conversation about suicide, create a connection, and acknowledge the anguish and pain. The simple act of asking about suicide risk is more predictive of a future suicide attempt than even cholesterol scores are for a future heart attack. Second, the strongest resource in preventing suicide is always the person at risk. By collaboratively designing safety crisis plans that include reducing access to lethal means and following up with phone calls after discharge, one recent study showed a 45% reduction in suicidal behavior. And third, we must treat suicide directly. We've assumed that treating mental health and/or addiction will fix suicide risk, but that doesn't always remedy the pain that underlie thoughts of suicide. Zero Suicide trains health professionals to deliver specific treatment, as well as caring and supportive contacts either between appointments or as post-care follow-up in the weeks and months to come. This relentless pursuit of perfection and insistence on evidence-based intervention works. Henry Ford saw a dramatic 80% reduction in suicide and maintained that success over a decade, including 1 year when they actually achieved zero. And at Nashville-based Centerstone, one of the largest nonprofit community mental health programs in the US, they reported a 64% reduction in suicide deaths since implementing these initiatives. And on the other side of the world, Gold Coast Health in Queensland has succeeded by utilizing the resources of the Suicide Prevention Resource Center, including a specific toolkit with a set of practices and resources for data collection and continuous quality improvement. Additionally, thousands of other organizations around the world are now taking their first steps towards zero suicide. Bold visions have put a man on the moon and cured polio, For suicide prevention, there's no more time for half measures and missed opportunities. Only with insightful leadership committed to the pursuit of zero suicide will we be able to make significant strides towards eradicating these tragedies. Zero suicide, healthcare that believes no one should die alone and in despair.
All right, so we can go on to the next slide. And
It's giving me a little trouble with that. Hang on. Let me get my other keyboard. There we go.
there we go. So just we'll get back to the I'm gonna comment on the video here in a minute, but a couple of facts, and most of this a lot of you guys are behavioral health or healthcare providers, so you're aware of some of these kind of individual facts. But it's the 10th leading cause of death, preventable death in the U.S. And you'll notice there that only 20% of folks have seen a mental health professional, in a couple of months before a suicide attempt, but they've seen 45% of them saw a primary care provider. So the point of entry or awareness, may well be in primary care rather than in its mental health. I mean, we would kind of expect mental health people to be checking on things like suicide and risk. It's where with primary care folks, that may be a little less common. So that's part of what the program is about, is helping primary care kind of get that as part of their integrated as part of their routine. 38% have visited, a primary care emergency department or something within a week. That to me is pretty significant. For about 40% have come in contact with some kind of healthcare provider the week before the attempt. The fact that 95% have, seen a healthcare provider within the past year just tells you that a lot of people, go see primary care doctors. But one of the major kind of things is that, and sometimes physicians and healthcare providers, not so much mental health providers, but healthcare providers have this, concern that, if they ask about lifestyle kind of factors, if they ask about how things are at home, if they ask about mental health problems, somehow the patients aren't going to like that. But, that fourth bullet there says that, people expect their physician to ask about lifestyle factors in terms of how things going at home and work and those kind of things. And so just being able to bring it up so that folks feel comfortable about commenting on it sometimes is a key thing. One of the significant things about zero suicide is we're going to try to do some harm reduction just by limiting people's access to things that they can hurt themselves with. We'll talk a little bit more about that, particularly firearms. So, in Oklahoma, a lot of people have firearms, but bringing that up is, you have ready access to firearms, and then maybe talking a little bit about it. Most suicides are kind of short-term crisis intervention. I mean, you see that sometimes when people have, chronic suicidal thoughts and so forth, and that does occur. But for a lot of people, it's a response to a short-term crisis. And that third bullet down there, that 90% of the attempters don't go on to eventually suicide later, to die by suicide later, is kind of proof that, you do have folks who repeat attempts, but for most people, those that survive, then they don't go on to try it again. And I've talked to a lot of people who said, boy, that I won't make that mistake again. You do see some people that, in a crisis may repeatedly do that, but the chances are that it's not going to be a repeating kind of thing. So I think we go to the next slide, Cheryl. Take a look at a few more facts. So the thing about zero suicide is individually as providers, we know a lot about suicide and how to assess and so forth and so on. But the idea with the zero suicide program is it's a program, and it involves a number of facets, about 7 or 8. We'll talk about those in a minute. But it's got these guiding principles, and one of them is you're going to have this quality improvement kind of thing going on. So we're going to continue to be looking at our patients and looking at our data and trying to see what we can do best. And the culture is that it's zero based. So, sometimes the idea is, a certain amount of people are just going to do that. But The idea is that no, you can drop that to zero. It doesn't have to be that. It doesn't have to be that way. And it's an orientation to changing the way the healthcare system, in this case, primary care, works, and the primary care practices are able to respond, flexibly to people who are having suicidal thoughts or at some risk for suicide. So they got the core values that it can be eliminated, that it doesn't have to be this way. It's a systems management approach, which means it's a whole practice approach. And then the specific interventions are going to be based on some evidence-based practices. So those are kind of the three foundational principles and kind of the mission. So Cheryl, we can go on to the next slide. So here are kind of the 7 or so elements. We're going to talk about these: lead, train, identify, engage, treat, transition, and improve. And so each one of these makes up the program. So Cheryl, we can talk about these in depth a little bit here. So the lead idea is that this is a systems-wide kind of thing, and it's from the top down. So the attending physicians, the people who run the practice, the organization has to say, this is something we want to see happen. This is something we're going to put in place, and we're going to make time for it, and we're going to have some champions for it, and we're going to change the way we do business so we accommodate folks who are having some suicidal risk or having those kind of thoughts. And so we're going to adopt a comprehensive approach to practice, and we're going to implement this program correctly, and we're going to make it the way we do business. So the lead piece, this really is not a bottom-up kind of approach. I mean, we certainly work with practices, but optimally, this is a top-down approach for the people who are in charge. Make this a priority for everybody else, and then of course allocate resources and time to implement the program. So we'll talk more about the QI facet of it here a little bit later. So we'll talk much about that. So train. So the whole idea is we're going to train people. We're going to train people appropriately at their level, and so we're going to have basically the philosophy. We're going to train people in the philosophy that suicide is just not an acceptable risk. That it can't be zero. We're going to do everything we can to prevent it, and that implementation of a zero suicide program will dramatically reduce, just like you saw in the video, dramatically reduce incidents. So we're going to put some protocols and we're going to put some procedures in place to kind of help with the workflow of implementing some of these strategies. And we're going to use evidence-based kinds of approaches, and we're going to train people. And so we want everybody to be trained. They want everybody to be retrained. New people retrained as they come into the workforce, and then everybody gets retrained every 3 years. So this idea of developing these skills, policies, procedures, workflow, and then keeping them going by talk about the continuous quality improvement bit here in a minute, and then by continual education and training. So it's a system-wide, practice-wide approach. So go on, Cheryl, to the next one. So one of the things is identify. So and that's so important. And so we're going to try to set up some policy procedures. Academic detailers will work with practices on how to set the screening up so that flows in your EMR, or how it flows with your intake or your the process of rooming patients, and how you can use some screening instruments. We'll talk about the Columbia here in a minute. And then how that documentation flows into the chart. It goes to the provider's aware of it. Then the provider's able to address it with the patient, and then whatever kind of intervention needs to take place can take place, and that may involve other folks in the practice, and so how that flows. So I know, my experience is that sometimes in small practices, something like this can happen, and it just kind of blows up the day for a small practice. Everybody's kind of scrambling around trying to figure out what to do. So part of the zero suicide program is to avoid that by putting measures in place and workflow in place and standardized screening and training in place so that it can just kind of flow with the workflow. So Sharon, click on that Columbia there. We'll just kind of go over this. This is really a great resource. Give you kind of a example on this. So that
Give me just a second. I got it on another monitor, and it'll be up in a moment.
Yeah, I've had that problem. So while Cheryl's doing that, any questions that we can talk about? Good. So scroll down, Cheryl. Let me see here. So see where it says learn. Let's go and learn more. Click on there, yeah. And then scroll down. So this is going to give you an example. We could work through here because then they've got these questionnaires for healthcare providers and mental health providers and different kind of folks. But you can, there we go. So you can go ahead and scroll down, Cheryl.
Oh,
Let's
okay.
Keep on going. Is that it? Is that the end? Keep on going. Keep on going.
Yeah, that's it.
All right. Well, then go back up there. So this is an example of what it looks like. So this is kind of the simple screening instrument. If you wish that you thought you're dead, in the past month and actually had thoughts to kill yourself, and then you go on to the third questions and then the sixth question. And it'll tell you whether the person's at high risk, low risk, or those kind of things. It's a little hard to get to, but there is a full Columbia. Let's see if we can find that real quick. Cheryl, scroll up a little bit. Okay. I had this saved on mine. Let's see here. Yeah, go to that protocol. Let's see what we can get there. No, I think, yeah, let's just kind of zip out of that and go back to the presentation.
I think it will be at the very end, at least we can point it out.
Yeah,
there.
we can look again. But there is a full Columbia screener on there, and it's worthwhile to take a look at that full Columbia screener because it's going to talk about intent, it's going to talk about planning, and it's going to talk about lethality, it's going to talk any number of those kind of things. So once a person screens positive with the screener, then a fuller assessment's done. And I've got some these are nifty little cards from SAMHSA, safety. I don't know if you can see that. But you can get these and order these, and then they're going to tell you about, what you need to do. So you need to identify protective factors, conduct a suicide inquiry, those kind of things. And then it gives you on the inside, it tells you about the risk factors, protective factors. So it's kind of a pocket card is handy, and you can get those from SAMHSA. It's got numbers on it and all those kind of things. So the idea here is that you're going to have universal screening. And so some providers will say, well, people are going to be uncomfortable to ask about those kind of things. But once generally people are not particularly uncomfortable. And once they kind of get in the flow that this is normal kind of questions, how are you doing? If you thought about hurting yourself, you had any thoughts you like die? I mean, those kind of things like that PHQ2 kind of question, people get used to it, and a lot of people will buzz right through it. But you will catch people who will say, yeah, I have been depressed, or yeah, I have had some of those kind of thoughts. And then you've identified them and you're ready to address it. Okay, so Cheryl, I think we go to the next slide. So one of the things we're going to do is engage. And so we're going to engage, we're going to try to work on a safety plan. And so when you're doing this, if it's into your workflow and you know what to do, and it's integrated into your EMR or your electronic health record, then it's much less of an ordeal. And it can just, okay, so we've got this case where we have somebody's thinking about that. And then we have particular protocols, just like we do with hypertension or something like that. And so we're just going to address that. And so, so this CALM is counseling on means access. You can click on that. We can go there real quick, just kind of show folks. And basically,
let me get it shared here.
This is training on how to talk with people who are having thoughts about hurting themselves, and it's ways to talk about reducing the lethality. So if you scroll down there, you can see this course description. So, the purpose is completing this course is you're going to explain, hang on there. Let's see what it says to go over this. So explain reducing access to lethal means. We're going to talk about reducing suicide can be prevented. And the whole idea is that if you can prevent somebody from accessing lethal means, that period of despondency or hopelessness will kind of will wash away. And particularly if somebody's in contact or with or follows up with them or gets them in touch with resources, then that impulse, like we talked about in the other slide, kind of goes away. But this is a kind of thing you can set up and you get a certificate of completion. But you can take an afternoon and set this up with your whole practice, and you can sit down and have some pizza and go through the course and buff up your skills in terms of identifying and describing strategies and talking with people who are having some thoughts of suicide or having thoughts of hurting themselves or just really depressed. So, all right, Cheryl. So,
Go
but I
back.
want everybody to see that, because that's that training is a good resource. So we go back to the slides. So the engage is the idea that we're just not going to note it, screen it. We're going to actually engage people. We're going to help them come up with the plan. So we can go on to the next slide, which is going to have to do with treat. And so once we engage them and we identify and we engage them, then this idea of treatment is we want to get them somewhere they're going to get some help. And so we want to use evidence-based interventions. And so we're going to do some reduction of lethal means. So they got guns at home, they have their son take the guns or have the father take the guns, or, do different kinds of things. In the past, you have to be careful about doing this. In the past, I've had people say, just take it down to the police station and hold it in their armory. And so, a patient walk in with a couple of guns to the police station. They get some attention today, but back in the day, that didn't get so much attention. The police were very helpful. They said, yes, we'd be happy to tag these and we'll hold them in our armory until a point where you think you're safe. So there's a number of different kind of strategies. Put them in your trunk. That's another one. Lock them in your trunk, because then you got to go get your keys. You got to go get your car. You got to go unlock the trunk, so there's some time in between there to think things out a little better. Some problem solving strategies that can be used, supporting people by giving them emergency numbers, those kind of things. Now, let's go through this, Cheryl, because I want to show the brown, if y'all don't know about this,
Okay.
this is the great little brown Stanley safety plan. And the nice thing is, so we'll show you how this works. So this gets integrated right into your workflow. You can sit with somebody, pull it up on the computer, and you can work right through it. So let's make a plan, Cheryl. So here we're going to talk about some warning signs. So, my warning signs, Cheryl, are when I get angry. So we type in angry there. That's a warning sign. Oh, look at there. So not eating, angry. Let's see. Not eating. We'll put that one down there. And then put isolation. That's the one that a lot of people do. There we go. So we can sit and talk with the patient here a little bit and say, okay, so what are your warning signs? What are the kind of things you want to pay attention to? And then we just hit next. And then we're going to talk about some coping strategies. So we click on there and we can just click on a coping strategy, like drawing. That might be one. So you can just click on that. You don't even have to run. Let's see what else. Maybe breathing, just a deep breathing, or maybe talking with somebody. So those would be, 3 things that would be kind of my coping strategies. And we hit next. And we're going to talk about some distractions. So these are the kind of things I could do, take my mind off. So I could listen to some music here again. And so we can tap that one, or I could play with my dog. That'd be pets down there at the very bottom. Or I could maybe call a friend. Let's see if that's on there. Yep, they're friends. So there we go. So those are some distractions that I can use. Now, what are my supports? So these are my personal support. So I could talk to my mom or dad. I could talk to, if I'm a religious person, I might talk to my priest or God or pray or whatever, that might work. And then I might talk with, some siblings or something like that. So that would be good. And then we're going to go on to professional support. So we can click on there. So you call your shrink, you can call your therapist. That'd be a good one. Let's see here. We could call the hotline. Let's try that suicide hotline. And then you could, call your school counselor, let's say. So anyway, something like that. So we'll click on next, and then we want a safe environment. Here we go. So we can type those in. So these are the kind of things we want to remove. So we want to get rid of the razors and the guns and the pills. So let's just say we're going to do those. So
Okay.
click or type those in there. Pills and just get rid of the guns. I don't think guns are in there. That's
I don't
weird.
think it's
though.
on there.
Huh? Stay away from the kitchen. You can just type the guns in there. If that's it.
Yeah, we'll type it in.
I think you can type that. Yeah.
Yeah.
Yep. Then you hit next and see, here you have it. Now you have your plan. So you can sit there and review it. And then you can go up here. And if you need to get immediate help, you can click there. But you can go on down to next, and we'll see what we're going to do. So you go down to next. And then you can email this, or you can send it with a text, or you can print it out, or you can download it. So however you want to do it. So if you wanted to give a copy to the patient, that'd be a good idea. And if you wanted to put a copy in the medical record, you'd have one downloaded there. So yeah, I think that's a good little plan. It'd be good to have that on your favorites at the practice, and be able to click in, when you identify somebody's having some problems, you click in. So you could have a nurse, you could have a mental health person, you could have, somebody sit with the person, kind of walk through it. And surprisingly or not surprisingly, that just doing this kind of thing can sometimes make a big difference in terms of whether somebody's going to act on those impulses. So I wanted to show you the Brown's Stanley Safety Plan template, because I think that's a great resource. All right, so let's go to the next slide. So we got a couple of slides on transition. So transition is important, and you can see that second bullet there is important. So we're identified in primary care. So we want to transition, if needed, to behavioral health, and that could be inpatient behavioral health, or it could be outpatient behavioral health. We don't want to put people in the hospital unnecessarily, just because they're having some thoughts. When we walk through the process, have them appropriately evaluated, maybe that they just need some regular intensive kind of outpatient to kind of help them get through that spot. Maybe there can be some safety plans, just like we talked about, worked out at home, or they're going to be with somebody and not having access to lethal means. So, but anyway, some kind of behavioral health intervention, and then back to primary care. So you're not going to lose your patients. And of course, if you're in a situation where you have mental health services in your primary care clinic, that's even better. If you don't, then in your primary care practice, one of the things you may want to think about is, and we'll get to this in the next slide, is how do you get an MOU, or how do you get some kind of agreement with your mental health provider, so you're able to make these transitions quickly. So that policy procedure there is important. But mainly, we don't want the patient to fall through the cracks. We want to track them. And so we can go to the next slide, Cheryl. Let's see, I was going to talk a little bit more about that. So I think it's on the next slide. We'll talk a little bit about some.
Okay.
Yeah, let's go back one. I'll pick this up here in a second. So going back, we're going to talk about this still in terms of these transitions. So the whole idea of tracking is important, because we don't want to just refer the patient down the road to, as a primary care provider, we don't want to just, send the person down to the ABC Community Mental Health Center, or down to the hospital's psychiatric ward, or to their emergency, and then they get screened and they get sent off somewhere. If you're in a rural area, we want to be able to track and follow your patients. And so having these MOUs and having these disaster management, we always do planning, and the reason we do planning is so that agencies get together and exchange business cards and talk to each other. So when a disaster happens, we know who each other are, and we've talked to each other before. It's same kind of thing in this situation. So it's good to have lunch with those people, have them over, intermingle, do those kind of things, so you know who you're talking to on the phone, and you have some agreement about how, when I call, that I can get somebody to come over to my place and visit with this patient, or I can send the patient over there and they'll be seen in a timely manner. They're going to call me back and they're going to say we started on a medication, or we didn't, or what we did. And so you're able to track and follow. So there's some things that practice facilitators can do to help kind of track this with your medical record, whether that's electronic medical record or whether that's a paper medical record. Hopefully it's electronic, but help you put some flags in place. So you're able to, you don't have to do all this manually. But it does very little good to screen somebody and then not bring it to the clinician's attention. So automatic flags can help with that. And there's some other strategies. Okay, sure. I think we can go on to the next one. So here's some kind of practical things. We already talked about some of this. This is still in the transition, but sitting with the patient, developing a safety plan, or having a conversation about how it's necessary to temporarily take some of those lethal means out of your hands or out of your house, so that, this will pass in 72 hours. Then we take a look at what we need to do. Generally for most people. The whole transition thing, from provider to provider, care level to care level. But, a call to the family or the patient, within, a couple of days, a day to 2 days, just to make sure everything's going okay and they follow through, can make a big difference. So personal phone calls, texts, sometimes postcards or those kind of things can be helpful. And letting the patient know that you're tracking, you're following, and you're interested. So that is part of the big deal on the last slide on transitions. So the next one we're going to talk about is improve. So this is the idea that hopefully, you're tied into your electronic medical record. And so data, as you're being screened, and data is kind of flowing into your medical record. And then you're able to pull some statistics, and you're able to look at, so how many folks do we have that come in and they came in and screened, at risk, and how many of those people then, were we able to resolve this in the office, and how many of those people didn't have to be referred, how many of them had to be admitted, did we catch up on the back end, did we follow up with the behavioral health folks, those kind of things. So the idea of improve, this kind of quality improvement piece we talked about at the very first slide, is the idea that leaders are going to make this an important part of the way we do business in this practice. They're going to keep on checking, and they're going to keep on acting and doing and checking and acting and doing and checking and acting and doing, just with the improvement process. So that's in place. And so we can look at parameters and look at age and look at response time, look at any number of kind of things, and try to see where we can do a little bit better. So we go on to the next slide there. So this is kind of an example. You can't see it very well. This is kind of an example of some basic data elements that, we can click on there.
Yeah, I think it comes up bigger and better. So let me get it up here just a second.
So it'll give you some idea of some of the kind of fields, variables that we kind of be looking at.
There.
Yeah, you might be able to increase that a little bit.
Yeah.
The size there.
Oops.
Yeah, so there we go. So we might be looking at, how many do we screen? And of course, with zero suicide, what we're really looking for is like screening 100%. But you may find that there's certain days of the week, or there's certain times or certain personnel that the screening kind of falls off. So then what would we do to augment that? And of those, then how many, what's your ratio of how many actually turned into an assessment? So they screened somewhat positive, and they needed a more detailed assessment. So, and sometimes, it's the more detailed assessment is, no, I really didn't mean that, or I'm having a bad day or something like that. So maybe a full safety plan like we just did isn't necessary, but maybe a callback is. So then you take a look at, so how many we screen, how many we actually need to assess, and then how many did we develop a safety plan? Then what were the means that they were going to use, and did we address that? That's always an important kind of thing. And then follow up missed appointments. So, that'd be important. So we're going to see you back in a couple of weeks or a week to see how things are going. Did they follow through? How many, needed to go to a hospital? And then of course, you'd want to do, rates of death and those kind of things. You might also look at, pull some stuff like, some markers like, separation, legal problems, substance use, all of those kind of things elevate risk. So, so you could work on that, and you could come up with some rates within your practice, and then you could kind of compare that with some benchmarking kind of statistics. And if you have multiple sites, then you can benchmark and compare against one another. So that's good. So, so I think in the last slide, Cheryl, if we can get back to it. I thought it was so let's go to the next slide. So we talked about the workflow and trying to implement a PHQ-9 or the PHQ-2 or the Columbia N. But if you go down, if you click on that link down there at the very bottom, that Chickasaw Nation. So there's a couple of, so that they implemented it and they found it to be very successful. I wanted to point out when it comes up, I think I can point out something pretty quick. So yeah, scroll down there. So see, they say they implemented it in 16 in their ED. Let's see here. And so they were running about let's see, where'd it go? So go, yeah, there you go. So they were running about 120 to 150 suicidal patients were admitted to the inpatient. So that's a lot of admissions. And between 16 and 17, you know, they were able to divert 200 diversions for inpatient admission. So then when you look at that cost, you know, so that inpatient cost is about $1,100. So basically they saved about $200,000 a year by implementing this program. So they were able to accurately identify people at risk. And then once they identified them at risk, they did a proper assessment and then they set up a plan. So and all about saving lives, but in terms of healthcare utilization and in terms of cost, a zero suicide program makes a lot of sense. And I think the Henry Ford little intro talk some about that. But that's a good example around here in Oklahoma. So you can go to the website and you can look at that, kind of see what they identified and kind of what they did. And it walks you through it.